We're going over pulmonary artery.
I don't see it online.
Sorry?
PowerPoint?
PowerPoint?
Yeah.
I thought it was online.
I got it, yeah.
You don't see
What is
it?
it called? I'm
Yeah,
not
it's
seeing
still there.
15.
Swan-Ganz catheter, yeah.
It's
So it's
kind
a
of in
pulmonary
the,
artery catheter.
It's on the 14th?
it's kind of in a weird spot.
Oh, I see. All right.
Okay. Otherwise known as the Swan-Ganz catheter. Those two guys were the ones that invented the pulmonary arterial catheter. And just like it sounds, the artery, the catheter is placed inside the pulmonary artery so that we can monitor hemodynamic pressures. And this is what it looks like. Okay? So before I start telling you more about it, let's go through the learning objectives. You will understand the indications for Swan-Ganz catheter. Understand which port of the Swan-Ganz catheter is used to measure CVP, right atrial pressure, PAP pressure, and waist pressure. Okay, so anytime we want to really monitor all the hemodynamic pressures, the patient is going to have the Swan-Ganz catheter put in. Know how to obtain waist pressure from a Swan-Ganz catheter. Know the complications of Swan-Ganz catheter. Trace the location of the Swan-Ganz catheter as it is being installed inside the heart. Okay? So now, another name for the Swan-Ganz catheter or the pulmonary artery catheter is balloon-tipped, flow-directed pulmonary artery catheter. That's what they more than likely call it on the exam. Or maybe they would say like BTFPAC on the exam. At the end of the catheter, you have a balloon right here. This one here is kind of like ruptured, but it's right here, you can see it. So basically, what we do is, once you get into inside the major vein, like subclavian vein, internal or external jugular vein, okay, if you get it in there, then you blow up the balloon. Okay, there's a place where you're gonna put some air, you blow it up, and then it drags the catheter around the heart. So the balloon will drag it past the tricuspid valve into the right ventricle, and then it drags it across the pulmonic valve, and then it goes into the pulmonary artery, and that's where it lodges. Okay, so the destination of the catheter is in the pulmonary artery. That's why we call it the pulmonary artery catheter. Any questions about that? So on the exam, when they say balloon-tipped, flow-directed pulmonary arterial catheter, they're talking about this. They don't call it Swan-Ganz catheter on the exam. The catheter comes in various sizes because you can cannulate a baby, you can cannulate a pediatric patient, you can cannulate an adult. So we have different sizes. It is, no matter who you are trying to cannulate, about 60 to 110 cm in length. Okay? And 48 French in caliber. Okay, just small enough to go into the pulmonary artery without causing occlusion inside the pulmonary artery. Okay, and then we have 48 French caliber. Okay, depending on the size that you want to use. And then another thing that you can see is that the shaft is calibrated in 10 cm increments. So if you look at it, 10 cm, you're going to see a little dark line there. As from here to here, 10 cm. From here to another dock line, 10 cm. From there to another dock line, 10 cm. So it is calibrated in 10 cm increments. So that helps us to know where the catheter is inside the heart by looking at the marks. So I can look at this. If it's right here, I can say, well, it's like 30 cm into the heart, okay? Or it's 2 cm into the heart. That lets you know that it's coming out or it's advancing moving, okay? So that's what that does. Any questions about that? Indications for Swan-Ganz catheter. Assessment of cardiovascular status and therapeutic response. And under that will include a patient who has had complicated myocardial infarction, heart attack, okay? When you have heart attack, your hemodynamic pressures will go out of whack, okay, because you lose cardiac contractility, okay, which will then affect your blood pressure. So we need to monitor that as the patient is being treated for that. Cardiogenic shock. Remember, shock basically means low blood pressure, period. That's what it means. And if you have had shock, then we're going to have to monitor your hemodynamic pressures. And you're going to need a Swan-Ganz catheter. CHF, we can do that. Structural defects such as the papillary muscle rupture. Now, the papillary muscle is a muscle that attaches to the caudate tendon. Okay, that neck, that stuff that looks like a net that pulls the valve open. When that muscle attached to the end of it contracts, that makes it to pull the valve open. Okay? Right ventricular infarction, cardiac tamponade or infusion, monitoring during and after an extensive surgery, major organ failure, and again shock, assessment of pulmonary status and therapeutic response. They have pulmonary edema or ARDS. That will mess up your hemodynamic pressures. So we need to be monitoring that. Acute respiratory failure, patients requiring fluid administration. Because like one of the things that affects blood pressure is fluid. So we're going to do fluid therapy, give you more fluid. We need to be monitoring your hemodynamic pressures and make sure that they're not going too high. Okay? So severe multiple trauma, they're going to be bleeding out, for instance, acute renal failure, large area and all full thickness bones, and sepsis. Sepsis is infection that has gone all over the body. So once you get the catheter in, these are all the pressures that you're going to measure or calculate for the ones that are measured. Okay? We can measure the right atrial pressure because this thing here goes to the right atrium. Okay? And then goes into the right ventricle. Okay? So we can measure the pressure inside the right atrium, right atrial pressure. We can measure the PAP pressure, the pressure inside the pulmonary artery, because this here, the tip of this is inside the pulmonary artery. So we can measure that. We can measure the waist pressure. But now, remember the waist pressure is on the left. It's the pressure used to monitor the left heart function. But while the catheter stops in the pulmonary artery, it doesn't go through the lungs and go through the pulmonary vein and then enters the left. No, it doesn't do that. But what we do is, when we get ready to measure the pressure from the left side, we blow up the balloon. Okay, if you blow it up, you're going to wedge the blood coming behind it from the pulmonary artery or from the right ventricle. You wedge that blood, and because you're wedging that blood, the pressure that is being measured now is the pressure coming from the left side. So that's the way we measure the waist pressure. So anytime we want to measure the waist pressure, we blow up the balloon. And then immediately we get the waist pressure, we deflate the balloon. so blood flow can continue. If you don't deflate the balloon after you've gotten your waist pressure, the patient may end up having pulmonary infection. Okay, so you do it fractions of minutes. And then we can shoot for cardiac output. Okay, we can measure our cardiac output through a process called thermodilution. And I'll explain that to you, thermodilution. Okay? And then from the measure the pressures, we can calculate our PVR, pulmonary vascular resistance. Okay. We can calculate our SVR. Okay. We can calculate our mean arterial pressure or mean pulmonary arterial pressure. And then we can calculate our arterial to venous oxygen content difference. So that's CaO2 minus CvO2. Okay, you all remember that. It reflects a lot to cardiac output. Okay. Anytime the arterial to venous oxygen content difference is increasing above 6, cardiac output is decreasing. Okay, so it's very important. So now this is where the catheter has been put in. So you can see it here. It's coming down here to a major vein here, goes into the superior vena cava, and then it goes into the right atrium. It goes through the tricuspid valve into the right ventricle, comes out through the pulmonic valve, and then ends up in the pulmonary artery. So that's the final destination of the catheter. Any questions about that? So another thing that you're going to see is, you're going to see these little things here sticking out, okay? That's what you are looking at there. Different ports, okay, different ports of this one-gas catheter. So let's talk about those. Now we have what we call the proximal port. Okay, the proximal port of the swan-gas catheter, opens up. It's a little hole that opens up about 30 cm from the tip of the catheter. Okay, 30 cm about right here. This is covering it right now. I can't see it. Right here. Okay, about 30 cm from the tip of the catheter. So once I have the catheter put in and have the end of it inside the pulmonary artery, the proximal port opens up in the right atrium. That little hole is inside the right atrium. So anytime I put something in the proximal port, which I think over there is, yeah. So anytime I put something, I squirt something inside the proximal port, it pours out inside the right atrium. Okay? And also through that hole, we can measure whatever pressure that we want to measure inside the right atrium. So it says that the proximal port opens to a lumen 30 cm from the tip of the catheter inside the right atrium. And then we use it to measure right atrial pressure. If I want to measure my right atrial pressure, I will measure it through the proximal port. It is also used for giving medications, IV fluids, electrolytes, and to sample right atrial blood. Yeah, like, the lab does like QAM blood work almost on anybody, So when they come in the morning, they want to draw blood from a patient. Instead of sticking the patient, they can give the nurse a syringe, okay, if the patient has one gas catheter in, and then they're going to hook it up to the proximal port and draw some blood and give it to them, okay? It saves the patient pain. The patient, it saves it because instead of poking the patient, you're doing that. Also, through the proximal port, we measure our cardiac output. Okay? Now it says that through it, the injected solution for cardiac output study is introduced. So what they do, we're gonna cover that down the line, is if I wanna shoot for my cardiac output, I will draw like maybe a few milliliters of normal saline, okay, of non-temperature. I will know the temperature of the normal saline, okay? And then I will squirt it through the proximal port, and then it pours out inside the right atrium. And once it pours out inside the right atrium, it cools the blood down. It cools the blood down, okay? And now that blood now that has been cooled down will travel around the heart. It will go into the right ventricle. It comes out into the pulmonary artery. There is a temperature-sensitive device at the tip of the catheter. Okay, we call it the thermistor. Okay, it senses changes in temperature. So now that blood that has been cooled down now comes all the way into the pulmonary artery, and then the thermistor notices that the temperature now is different, and then it will communicate that information to the cardiac output monitor, the big monitor, cardiac output monitor. And then the cardiac output monitor will use that information, the difference in temperature, and calculate the cardiac output and display it on the monitor. Okay, that is called the thermodilution. You are diluting the temperature of the blood. Dilution. Okay? So it all begins from the proximal port. Put that saline there, it pours out, cools the blood down, the cooled blood now flows down the line to the end of to the tip of the catheter, and then the thermistor senses the change in temperature, communicates to the cardiac output monitor, and then the cardiac output is calculated and displayed on the monitor. Any questions about that? So just know now that the proximal port is used to measure the right atrial pressure. We can use it to administer fluid. We can use it to shoot for cardiac outputs. And then we have the distal port, okay? It says that the distal port opens to a lumen that runs the length of the catheter and terminates at the tip of the catheter, right here at the very tip. If you look at the very tip, you can see this little hole in there, at the tip of it. Where's the other one? Okay, yeah, so it's right there at the tip. That's the distal port. Now, so since the end of the catheter is inside the pulmonary artery, then that means that the distal port opens up in the pulmonary artery. That's where it is. Okay. So now, if I take the distal port, this one here, no, where am I at? I think it's this one here. If I put something in the distal port, it pours out inside the pulmonary artery. It pours out inside the pulmonary artery. So
does that open the right ventricle?
huh?
The right ventricle?
Yeah, it's going to go past the right ventricle, and then this here ends up inside the pulmonary artery. So anything that you put into the distal port will go through there and then pours out inside the pulmonary artery. So this thing is like you have the catheter, and then if you have your proximal port, it has its own channel. It goes through there, and then you have the distal port, it goes through there. It's just one catheter, but on the inside of it, you have different channels. Okay? Now, since the distal port opens up in the pulmonary artery, we can use it to measure our PAP pressure, because remember, PAP pressure is the pressure inside the pulmonary artery, or pulmonary system. Now, we can also use it to measure the waist pressure. Remember, the balloon is at the tip, and once we blow up the balloon, we're blocking the blood behind it, and then we'll measure the pressure coming in front of it. Okay, so you don't have to do that. We use it to sample mixed venous blood. Now, mixed venous blood is inside the pulmonary artery, not the right atrium. Okay? Yeah, I mean, it's still the oxygenated blood, but once the blood returns to the right heart, by the time it gets inside the pulmonary artery, it has actually mixed up very well. Okay, it has quite mixed up very well. So, if you want to run a blood gas, VBG, okay, venous blood gas, you get it from the pulmonary artery through the distal port. Okay? Now, I think I've told you this before. If you want to know how well the lungs are working, you get an arterial blood gas. And if you want to know how well the heart is working, you get a venous blood gas. Okay, so if we want to determine the function of the heart, we will be drawing the oxygenated blood from the pulmonary artery through the distal port. We call that mixed venous sample. Okay? That's very important to know. Mixed venous blood gas is drawn from the pulmonary artery because that's, by the time the blood gets there, it's actually mixed up very well. It is not used to administer medications. We don't put medications or fluid inside an artery. We don't do that. Okay. We'll put it inside a vein, okay, or we can pour it inside the chamber, you know, but we don't, you know, do IV in the artery. Okay. Any questions about the distal port? Obtaining wedge pressure. Now, again, the wedge pressure is the pressure that we use to monitor the function of the left heart. And like I said before, we are going to inflate the balloon at the tip of the catheter. Okay? And once you blow it up, you're blocking blood flow behind it, and then measuring the pressure that is coming from the other side of the heart. Okay. That has to be very quick. It has to be very quick because once you blow up the balloon, there's no more blood now flowing through the pulmonary artery to the lungs. You don't have any blood going to the lungs temporarily. Okay, so if you have it inflated for a while, then you cause pulmonary infection because the lungs are going to be going without blood, not being perfused. So it's very fast, okay? And once you've done that and you look at the monitor and you get your waist pressure, you should immediately deflate the balloon, okay? So that blood flow can continue through the lungs. Any questions? It tells you here, more than 15 seconds is not really good, okay? 15 seconds or less to get your wedge pressure. Okay, so balloon inflation port, okay, opens to a lumen that terminates within the balloon. So right here where the balloon is, there's a little hole here. So once if you want to inflate the balloon, you put your syringe, let me see which one, right here. You put your syringe here, and then you put some air there, it goes through there, and inflates the balloon. So it kind of looks, when you inflate it, it kind of looks like that. Okay? So when you get ready to inflate it, usually about 0.5 to 1.5 milliliter of air. It's all that you need. Because you don't want it to blow up. You don't want the balloon to rupture. Just like the ET tube cuff. You know, anytime the ET tube cuff ruptures, what do? You have to extubate your patient, right? And put in another one. Okay? Now, if your patient is very difficult to intubate, then you got a problem. So there's something here. You know, if it ruptures, we have to bring it out. In fact, it's more problem bringing this out, getting it out, than putting it in. Because as you're pulling it out of the artery, you can cause a lot of damage. So it's not something that we like to do frequently unless we have to do that. So you gotta be careful not to put too much air there to cause the balloon to rupture. Okay, so now the balloon is only inflated in 2 occasions. You gotta know that. And that is during insertion. Once you get inside the major vein, whichever one that you're using, you inflate it. Usually the patient will cough. Okay, that is documented with cough. Okay? And then you allow the blood flow to drag it all the way into the pulmonary artery. And once it gets into the pulmonary artery, you deflate the balloon. The next time that you have to inflate it will be when you want to get your waist pressure.
How do you know it's in the pulmonary artery?
Huh?
How do you know it's in the pulmonary artery?
I'll get to that. You look at the word forms. Okay, I'll tell you. You look at the word forms, because what they do, once they get it inside the major vein, then they use the X-ray, fluoro, okay, and they can see it going through the heart. Did you all ever do rotation through the cath lab?
Mm-hmm.
Okay, so basically, they will put things like that in the cath lab, and then they have a little TV there, you can see it going in, okay? All right, so here is that thermistor, okay? Thermistor is at the end of the catheter. What it does is to sense changes in temperature, okay? And it's very important when we're shooting for our cardiac output, because that is what is going to sense the change in temperature that will be used to calculate cardiac output, okay? Now let's review a little bit here. Which port of the Swan-Ganz catheter is used to measure the right atrial pressure?
Proximal?
The proximal port. Yeah, the proximal port opens up in the right atrium. Which port of the Swan-Ganz catheter is used to measure the PAP pressure? The distal port. Yeah. In what 2 occasions?
Hi, Dr. O, sorry to interrupt.
Yeah.
This is Erin Palermo. We're gonna be meeting in my office in a minute. I just wanted to show her the classroom. These are the seniors. You may have
What's her
seen
name
them.
again? How much air is used for the inflation of the balloon?
I do believe we skipped one.
0.5 to 1.5 milliliter. Which part of the Swan-Ganz catheter is used to sample mixed venous blood gas? The distal port. The distal port. Okay, so we always like to get that blood from the pulmonary artery. Okay, so now, since this is intravascular catheter, we also have to hook it up to a fluid-filled system like what I showed you the other day. Anytime you put in an intravascular catheter, you have to, hook it up to a fluid-filled system. So we're going to have our IV pole and pressure bag. Remember now we are inside the artery, so the pressure there will be about 300. So we need a back pressure that is that much, or at least greater than the patient's systolic pressure, to prevent backflow of blood. Okay. We need transducer, we need a holder, we need a 3-way stopcock if you want to draw blood from there, if you want to do the mixed venous sample. We need a bag of fluid solution, they use normal saline, okay? They don't like to use dextrose. Dextrose is like a fluid that it's got sugar in it. Okay, it's got sugar in it. So if somebody, no, that's not what I meant to say. Sugar promotes bacterial growth. Okay, sugar promotes bacterial growth. Okay, so they don't use it unless they have to. If somebody is diabetic, you want to give them fluid, you're not going to give them dextrose, you know. But if their blood sugar is low, they have hypoglycemia, and they're needing fluid, yeah, we can give them dextrose. Okay. All right. Must always test the balloon for leaks prior to insertion, just like we do for ET tube. Because if you waste your time and take your time and get all of this here inside the pulmonary artery, only to realize that the balloon is ruptured, you know, that would not be a good experience. Okay, we want to make sure that we check it, make sure that it can inflate and deflate before we put it in there. Okay? I'll give you a break in a minute. We can actually finish this, it's not a big deal. Okay, so now again, yeah, once you get that, once you get it inside the major thoracic vein, the patient is gonna cough, okay? And then pressure wave is observed and documented to identify the location of the catheter. There's a little TV here, they call it the fluoro. You can actually see the catheter. So this is what they're looking at, okay? So now, when the catheter goes inside the right atrium, what's normal right atrial pressure?
2 to 6.
2 to 6, right? So now you can see now, it goes about 2 to 6, the amplitude of the wave. It goes like this. So you would know that it now is inside the right ventricle. And then finally, the balloon drags it inside the right ventricle. What's the pressure in there? 25, okay? 25. Okay, so there's more pressure inside the right ventricle than inside the right atrium. So because you have more pressure there, 25 over 0, it will now go like that. So that lets you know that it's now inside the right ventricle. And then the balloon drags it into the pulmonary artery. We're talking about an artery now. Anytime you cannulate an artery, you're going to see that at the carotid notch. Okay, so now inside the pulmonary artery, we'll start seeing something like this. So when we see this, we now know that the catheter is inside the pulmonary artery because we can see the carotid notch. Okay? And then what you're going to see is the next one here, your wedge pressure. Because remember, it is inflated once it gets inside the pulmonary artery. It's still inflated. Okay, so you can see your wedge pressure. But now, once it's there and you're seeing your wedge pressure, you go ahead and deflate the balloon so that blood flow will keep on moving. And then once you deflate your balloon, it's like this. There's nothing. Okay, the only time you see this here is when the balloon is inflated. Okay? So that's where it should remain unless you're trying to get your wedge pressure and then you go back there and put some more air in it. And then you get your wedge pressure immediately, you deflate it. Any questions about that?
What are the insertion sites?
Hmm?
The insertion sites?
What you say?
Insert site, insertion.
Insertion site, okay,
Yes.
sorry. I don't know what I'm getting deaf or something. Or maybe developing hearing problem. Insertion site, you can do, internal or external jugular vein. You can do the subclavian vein. We'll try to avoid putting anything inside the subclavian vein because it's very close to the lungs. If you're not very careful, you puncture the lungs and then the patient develops pneumothorax. So we're trying to avoid it, but we can use it. Or maybe you can do a femoral vein as well. Femoral vein, okay?
Thank you.
You're welcome. All right, so here, so we always take X-ray. Anytime you put in a catheter, just like the ET tube, you have to get X-ray. That's protocol to know where it is. Okay? And make sure that you're really at a pneumothorax. Okay, the tip should not be beyond the silhouette, the shadow of the mediastinal structures. Okay? Otherwise, it is advanced too far into the pulmonary vasculature and will not give accurate values. We don't want it to go way down into the pulmonary artery. Okay? Complications. These are the complications that can result from this Swan-Ganz catheter. You can have arrhythmias, balloon rupture, kinking, structural damage of the valve. Because see, this sits on top of the valve. It goes through there, it sits on top of the tricuspid valve, it's sitting on top of the pulmonary valve. The entire time the patient is using this. Okay? Infection can result, thromboembolism, pneumothorax, pulmonary artery rupture or damage.
So that doesn't make sense. Sits on top of it,
Mm-hmm. Yeah, like it goes through the.
so it's going through the opening.
It goes through the opening, and then here's the opening, then it's resting like that.
So the valve is malleable enough that it is able to close around that.
Yeah, the valve will close around it, correct. Yeah, it may not close completely. You may have a little bit of regurgitation during contractions. Okay. All right, so arrhythmias. Well, this is going into the right side of the heart. The primary pacemaker of the heart, the SA node, is about right here. So it will irritate the SA node sometimes and causes it to try to fire at the faster rate. Okay, so we have arrhythmias as a result of that. Balloon rupture. Okay, yeah. You want to make sure that you're using the accurate amount of air, 0.5 to 1.5 milliliter, okay, to do it. But just like any balloon, if you keep on inflating and deflating, keep on inflating and deflating, it gets weaker, right? It can rupture anyway. So for the balloon here, you can only inflate and deflate 72 times. Okay, after 72 times, the tendency for it to rupture increases, right? The tendency for it to rupture increases. So the lifetime of the balloon is 72 inflations. But there is something that we can do to prevent exceeding 72 inflations. Okay, so now, the PAP diastolic pressure, approximates the wedge pressure. The PAP diastolic pressure, like the 25/10. So this is my diastolic. It approximates my wedge pressure. So in other words, at any given time, I can look at my PAP diastolic pressure and say, well, yeah, my waist pressure is about 10. If my PAP is 25/8, I can say, yeah, my waist pressure is about 8. If my PAP diastolic is 5, I can say, yeah, my waist pressure is about 5. Okay, so sometimes we look at that instead of trying to, inflate and deflate the balloon. If the patient is going to need this for a while, this is not something that you put in and then the next day you get it out. The entire time that the patient is sick, they will have this in unless they have infection somehow. So, in order to avoid exceeding 72, that's what we're going to do. Sometimes we use our PAP diastolic. Any questions about that? Kinking there is very common, especially when you're using a very small caliber catheter. Okay? And it's not a good thing to happen because if it kinks, okay, and you're trying to get it out, you can actually rupture the blood vessel because this is what you're pulling out. Remember, the diameter of the blood vessel probably a little bit bigger than this, and now it's this way, and you try to pull it out. Sometimes a patient may have to undergo surgery to have it removed. Okay? If you can't get it out, if you keep on pulling it, it's not coming, well, you can, use like a tray line attached to it and pull it. You call the doctor, right? Get a tray line here. You know where a tray line, the big truck, right? Yeah, come on, let's pull it. All right, any questions about kinking? Structural damage to the valve can happen to the valve as well. Avoid prolonged catheterization. Okay, so any indwelling catheter, maybe 7 days, okay, or so. Okay, if they really more than 7 days, we may have to take it out and put it somewhere else because it will kind of like erode the blood vessel. It will erode the blood vessel as you flush and do other things. It can erode the blood vessel. Always deflate balloon when the waist pressure is not being measured.
You said it was every 7 days?
Huh? 7 days, about 7 days, yeah.
So what happens with, like if someone's in the hospital for a really long time and they're just not getting better, like you can change the insertion site, I know that, but it's still going to be resting inside the atria and the ventricles.
Yeah, of course it depends on the doctor, okay? Sometimes it's in there longer than that, okay? The main trait there is once the patient begins to develop fever of unknown etiology, then we're going to have to assume that there's infection to it. And that's when you want to get it out. But sometimes doctors can go a little bit longer than that. But textbook-wise, you go with 7 days. Okay?
But would it not be like eroding or causing damage to the inside of the heart as well, like the way it does the blood vessels?
Yeah, in fact, the longer you leave it there, the more it will tend to cause problems. There's no question about that. But sometimes, getting this out is actually more dangerous than putting it in. So if you think about what you're going to go through to pull it out, or maybe cause some damage to their blood vessels, you're probably better off leaving it there if there is no sign of infection.
How often would you be checking the pressure? I mean, 72 seems like a lot for 7 days.
Oh, the nurses count it. They chart it just like we chart everything else.
I mean, would you be taking it every hour? Or, I mean, how often are you going to be doing that?
Not quite. Usually at the beginning of the shift,
Okay.
or anytime there is a question about the pressure, you don't believe it. Okay? If you don't believe it, then you do that. Okay? But usually at the beginning of the shift, every nurse likes to know what the waist pressure is. Even though they get that at the report, right? It's just like somebody telling you they report that a patient's heart rate was 60 when they were doing their behavioral therapy. Well, that doesn't mean when you go do yours, you don't have to check their heart rate, right? You still have to check your own heart rate. All right? Yeah. At least every shift for the nurses. Okay, yeah, sorry. You know, these are the bacteria that can cause problems, okay, cause infection. Enterobacter, Klebsiella, they can get Pseudomonas, they can get E. coli, they can even get fungus infection. Okay, usually at the tip of the catheter. Okay, and again, if they suspect that it is infected, once they get it out, they will culture the tip of it. They just clip it right here, and then they take it to the lab and culture it to find out which bacteria that is causing the problem. We'll call that lab culture and sensitivity lab. Thromboembolism, clot formation, especially in patients that have circulatory failure. Okay. Now a clot may form this due to the catheter, and okay. Polyvinyl product is known to induce blood clot like this. This is kind of like a rubber. There's more tendency for you to form a clot with this inside the body. Clot may result in ischemic injury or pulmonary embolism. Yeah. Once that clot turns loose from the tip of this, it will embolize. Okay? If it goes ahead and enters the lung, that's pulmonary embolism. Okay? So again, anytime there's an obstruction, you're going to know because the wet form is going to change. You have damped wet form. What used to be normal is no longer normal. When you look at this, you don't see these here. Something's wrong with the catheter. Okay, you're going to have to draw blood from it to see if you clear it, or you rotate the catheter, or you flush it. Okay? Pneumothorax can result, especially when you're doing the subclavian vein. So, but whether you are using subclavian vein or any other major vein, once you get it in there, we have to do X-ray to rule out pneumothorax. Any type of intravascular catheter, you have to do an X-ray. Pulmonary ischemia or infection, okay. Mechanical occlusion of the pulmonary artery by clot. Okay, you have a clot at the tip of the catheter. It's big, and it liberates from the catheter, and then there's your pulmonary artery, and then it blocks it. Okay, that's a problem. Or persistent wedging of the catheter. Okay, putting air in it, putting down, putting air in it, putting down. More often will cause that. Okay, because then that prevents blood flow to the lungs. Okay, anytime you blow it up, you are temporarily blowing blood flow to the heart. Let's review here. Name 2 complications of the Swan-Ganz catheter. 2 complications. Infection is one of them, right? What's nesting? They can kink, yeah. Yeah, that's correct. Where is the location of the Swan-Ganz catheter in the heart during insertion when the dichrotic notch is observed on the waveform? Inside the pulmonary artery. Inside the pulmonary artery. How is wedge pressure obtained? Who can explain that? How is the wedge pressure obtained? You inflate the balloon, okay? And by doing that, you are blocking blood flow behind it. Remember, you gotta use volume to build pressure. So if I'm blocking the blood flow behind it, what is building the pressure is on the other side. Okay, so I'll measure the pressure coming from the left side of the heart. Okay, and then immediately after I have gotten my waist pressure, I'm going to deflect the balloon so blood flow can continue so that we don't cause pulmonary infection. All right.